So welcome to the Cancer Prevention and Wellness lecture for November. We'll get started in a couple minutes. Thanks for being here. So welcome. I'm Dr. Jeff Jagger. I am your host for this evening. This is the Cancer Survivors Park Alliance monthly cancer prevention and wellness lecture. A couple of groundkeeping issues, housekeeping issues. The audience, that being you, is muted throughout this. You are encouraged to ask questions through the chat feature, and we'll be monitoring that and asking our presenter questions that come through the chat feature. It is also the case that we are on Zoom, and we'll be recording this on Zoom, and this will show up on the Cancer Survivors Park website in a couple of days, so you can access it there or have your friends and colleagues access it there. That website is Cancer Survivors Park, all one word, .org. Tonight, we are pleased to have with us LeAnn Perkins. LeAnn is a nurse practitioner and is also a diplomat at with the American Academy of, or the American College of Lifestyle Medicine. She really has been instrumental in the programmatic development of all these clinics that we have at the Center for Integrative Oncology and Survivorship at Prisma Health. She's very innovative, very smart. She is going to be talking tonight about breast cancer risk, which is still, I think, it's always been the statistics for many years that 1 out of 8 women in this country are going to develop some kind of breast cancer. So we're going to talk about breast cancer risk and strategies for prevention. So LeAnn, thanks so much for being here and sharing your knowledge and your expertise with us. And let's go ahead and get started.
Thank you, and welcome everyone. So my talk this evening is breast cancer risk and strategies for prevention. And while there are some things that we can do to prevent cancer, there are times that cancer is not preventable. So we certainly don't want to ever imply that if you've had cancer or if you develop cancer, that all of it could have been prevented or that there was something that you necessarily did. Although we do have modifiable and non-modifiable risk factors, which is especially what I'll be covering tonight, and just some information about breast cancer in general. And my slide won't progress.
We have technological issues always.
Okay, it was working fine. Okay.
There you go. There you go.
So this is me, and I am a family nurse practitioner, certified lifestyle medicine professional, worked for 6 years in internal medicine as a nurse practitioner, and now I've been in oncology for 13, especially this last couple focusing on cancer prevention. So as Dr. Jagir said, roughly 1 in 8 women in the United States will develop an invasive breast cancer in their lifetime, and the 2021 statistics show that 281,000 women were diagnosed with breast cancer. So this is the second leading cause of death in women. This is about 12% of the female population when you say 1 in 8. So there are different screening guidelines, but looking at the American Cancer Society screening recommendations, women age 40 to 44 should start having a conversation with their provider about mammograms and screening for breast cancer. This is for people who are at average risk. There are some women who are at higher than average risk, and that might change. The recommendations for screening might change for them, which we will get into later. Age 45 and up, we really recommend in Prisma Health screening mammograms every year, but sometimes women decide after the age of 55, if they're average risk, to decrease that frequency, and that's a conversation to have with their provider. So understanding your risk of
So
breast cancer.
LeAnn, how did you come up with that? There's so many groups that make that recommendation, and obviously the radiologists want that to happen more often. Is that something that's kind of a conglomeration of all the different interest groups that make these recommendations?
There are about 7 different guideline groups.
Right.
I recently looked at them, and the majority of them, the recommendation is to begin at 40 and screen until 10 years of life expectancy. So if you have 10 years of life expectancy left based on other comorbid issues, the recommendation would be to continue screening. American Cancer Society starts theirs, as we just covered, 40 to 44, have a conversation with the doctor. The United States Preventative Service Task Force, or USPSTF, actually has later guidelines starting at 50. So there are times that conversations that patients have with their providers differ from one place to another, and this can be very confusing for people. Right. So I try to stick with the American Cancer Society. At Prisma Health, our recommendation is to begin at 40 and screen until life expectancy of 10 years.
Thank you.
So going on, understanding your risk, how would you know if you're above average risk? So only about 5 to 10% of breast cancers are actually related to DNA or being passed down in the family in genetics, which some people already know that they have genetic mutations. Some people don't. Some people will find out in the future. But another 15 to 20% are what we call familial. This means running in the family, but genetic testing has been done and nothing has been found. Another 70–80% of cancers are just sporadic, or they're related to modifiable, non-modifiable risk factors. Some non-modifiable risk factors that we talk about, this is something that you cannot do anything really about. Screening to find something early is the best thing that you can do. One is increasing age. That is the #1 non-modifiable risk factor. With age comes an increased risk of cancer. Inherited genetic mutations, you can't change, but you can do screening and live a healthy lifestyle. Increased density on the screening mammogram. This is not how your breasts feel, but what shows up on the mammogram. Increased density is a risk factor in itself because there's so much active tissue in the breast. And this doesn't mean in girls, young ladies who are in their 20s and 30s. It's normal to have dense breast in the younger years, but we're talking about as you age, 40s, 50s, 60s. And then a history of a biopsy with certain atypical cells. So for instance, atypical ductal hyperplasia is one. So basically atypical cells in the breast heading towards breast cancer. Family history of breast or ovarian, and prior radiation therapy to the chest between the ages of 10 and 30.
So LeAnn, in the perimenopausal age group, having dense breasts is actually an increased risk for breast cancer. It's not so much that it's harder for the mammographers to find the breast cancer. It is actually a case where the incidence increases.
That is true because of the activity in the breast. That is a risk factor of itself. It is true that it can be harder for the mammographers to see, for the radiologist to read it and actually see breast cancers.
Right.
And I have an example of that in just a little bit. I have a real nice slide that covers dense breast.
Right.
And these are reproductive factors, risk factors that just are. So starting a menstrual cycle before the age of 12, going through menopause after 55, not having children, or giving birth to your first child after 30, or not breastfeeding. These are things that you can't really change. Your body is your body. And it has to do with the amount of estrogen and hormones you're exposed to through those years. So this is the dense breast example slide. So you can see the breast on the far left if you're able to look at the slides. If not, you can look at these later, or you can reference this website, densebreastinfo.org, or the American Cancer Society has this as well. There are a fatty breast on the far left. The next is an average dense breast. The next is what we call heterogeneously dense. On a mammogram, it may be called category C. And then on the right is extremely dense. So you can see it's harder to see a white spot in these dense breasts. It gets kind of mixed in, and that's what the radiologist would be looking for, is a white spot in this. So there are a number of states who have, in the states number about 30 something, have laws that say that the density of your breast should be reported on your mammogram. And then there are 20 something states who have already enacted laws that say that the insurance company has to pay for increased imaging, such as breast MRIs or ultrasounds.
Okay.
So number one thing to do is to find out about your family history. Family history is very important, as we talked about genetics, as we talked about just being passed down in the family. Find out from your family who had cancer, when they had it, and what type of cancer it was. So this isn't just for breast. This is for pancreatic, ovarian, prostate, all cancers. What type of cancer did the person have, and how old were they when they were diagnosed with cancer? And then discuss this with your medical team. So the family history alone affects your risk. Genetic counseling may be warranted depending on what you find out about your family, and increased surveillance or screening may be warranted whether you do genetic counseling or not.
You know, one of the things you said was that one of the factors, non-modifiable, was age. And so one of the things you're emphasizing here is that if you have a family history of somebody who developed a breast cancer at a younger than usual age, that may be more of a thing to raise your concern.
That is correct. If you have in your family, if there's a lot of breast cancers or ovarian cancers in the 30s, 40s, younger people getting cancer, then that might be that there is something that is being inherited and going along in the family, versus if you have 5 aunts who have had breast cancer, but they were all in their 70s postmenopausal. That's not quite as alarming, although it could be important as well. These are examples of genetic risk factors that we talk about. So a lot of people have heard of the BRCA or BRCA genes, different pronunciations of the BRCA. These, about 50% of inherited breast cancers are from these gene mutations. Then there are some others, though. So it's important for people to know that BRCA testing only is not the only genetic testing they need to have done if they're interested in learning about their whole risk of cancer or breast cancer. BRCA genes are very important. However, there can be other genes running along in the family, and if everybody's getting tested only for BRCA, then they may miss the fact that CHEK2 or PALB2 or ATM, that these are also related to an increased risk of breast cancer and other cancers. So genetic testing is done by blood test or even by saliva test. And best, in my opinion, after meeting with a genetic counselor who really talks with you about your family history and decides with you what the best testing is to have done.
And it's fair to say that that is an aspect of medicine that is evolving. I think that when you developed some of the programs of CIOS. 5 years later, probably 3 of those 6 that are beyond BRCA have been new to a concern that might be leading to a genetic risk of breast cancer. So it's a constantly evolving field.
That is absolutely true. And which also brings to point that if someone was diagnosed with breast cancer 6-7 years ago, the genetic testing they did may not cover all of the genes.
Right.
And there are times that we bring people in for increased testing and we find out, for more expanded testing, we find out that they have a gene mutation that sure enough increased the risk of breast cancer, but we didn't know it when they had their first testing. So some other risk factors for breast cancer that are modifiable are being obesity postmenopausally, or being overweight. So sometimes we use the BMI chart, which we know isn't perfect. Some people fall outside of the BMI recommendations because they're very muscular, but on average, a BMI over 25 means a little overweight, and 30 would be obese. So kind of just taking a look, there are BMI charts online that you can take a look at and just see where you fall. So that is a big risk factor. Alcohol consumption is as well. The recommendation is not to drink alcohol at all, but if you do, trying to limit that to 1 alcoholic beverage in a 24-hour period, which would, we will talk about the sizes of that later. Physical activity, exercising 150 to 300 minutes a week is recommended. That can be split up however you want, but exercise decreases inflammation in the body. It improves the immune system, immune function, and it decreases overabundance of hormones. Tobacco use, I think we most know, increases cancer risk. Hormone intake, so this would be postmenopausal hormones, even oral contraceptives. Breastfeeding actually decreases the risk of breast cancer when you're young enough to have babies and breastfeed, of course. So being overweight, as we talked about, and this is a picture of all the cancers that are related to or increased due to being overweight or obese. So this is something to take a look at. Ovarian, endometrial, absolutely. Endometrial cancer, I think probably one of the #1 risk factors is obesity. So these are important to know, and exercise also helps to keep your weight in check. Alcohol, as we said, so 1 alcoholic beverage per day or less. So that would be 5 ounces of wine, 1 ounce of liquor, or 12 ounces of beer. And this is for women. Men can actually tolerate 2 and can actually break down the alcohol in a 24-hour period. So this is a picture of what those sizes look like. So making sure that the glass of wine is 5 ounces and not more than that, and you can take a look at this for yourself. So a sedentary lifestyle is a risk factor, so increasing your physical activity can help decrease your risk, as we talked about. So especially lots of research done around breast cancer and colon cancer, especially in exercise. And as I said, it helps keep your weight in check as well, for the most part. There are times that we exercise and you just feel more hungry. So sometimes it's difficult to lose weight if you're doing overabundance of exercise, because you do feel like eating more. So I can appreciate that. But the goal is to work towards exercising. The American Institute for Cancer Research has a fabulous website that covers all of these topics. A lot of people ask about sugar, and does sugar cause cancer? Does sugar feed cancer? So we don't really say that sugar causes cancer or necessarily feeds cancer. We don't understand all the connections of that yet. Certainly sugar, overabundances of sugar or simple carbs can cause inflammation in the body and can also trigger weight gain as well, or cause us to have a harder time losing weight. Can also take up calories that you need that could have been spent on fruits and vegetables and healthier things. So we're talking about table sugar, not talking about what you find in fruit, natural sugars, and not even talking about what you find in milk, which is lactose. Sugar also causes what's called hyperinsulinemia, or an increase in your insulin, and this can trigger inflammation in the body as well as a lot of other issues. So limiting to 26 grams a day is kind of what we say, and that's the American Cardiology and American Diabetic Association recommendations. So what can you do about all this? You can prioritize your movement, healthy weight, maintaining a healthy weight, avoiding alcohol, breastfeed when you are young and can do that, and get screened for cancer appropriately. So this is actually a little overarching package information sheet from the American Institute for Cancer Research. So this came from the May 2018 third expert report covering their 10 recommendations in addition to not smoking or using tobacco products and avoiding too much sun exposure. So each of these little bubbles has information beside it a little bit, but on their website, you can learn all about this. They even have a little healthy check that you can log on to, answer about 10 or 12 little questions, and it'll send you an email telling how you're doing with each of these topics to help you with your risk reduction.
So one of the things that we try to emphasize in this lecture series is data-driven, scientifically based information. And when you have those two entities, World Cancer Research Fund and the American Institute of Cancer Research, backing these recommendations, that implies that they have been truly scientifically evaluated. And I think the overall theme here is that even though you may have a genetic risk, you may have a familial risk for breast cancer, you do not have to passively accept that. There are still things that you can do to mitigate that risk and increase your likelihood of having a life free of cancer.
That is absolutely correct. And we also talk about what's called phytochemicals, and those are the chemicals, the nutrients that are in fruits and vegetables and even some nuts and coffee and different foods, and how these phytochemicals all work synergistically together to help decrease inflammation in your body and help your body's DNA repair itself properly. So you're right, some of the gene mutations have to do with repairing DNA, and so you certainly might not be able to completely overcome things, but you're right, a healthy lifestyle is positive and can help. And as you said, the data-driven on the American Institute for Cancer Research website, which is aicr.org, they actually have their third expert report that you can look on their website, and you can download the whole expert report onto your computer, and it's separated nicely into groups. There's one little book on dairy products and fish, and then there's a little book on exercise and physical activity, and then there's one on red and processed meats. So you can look at the little books, and at the end of each little book, there's the references and all the studies that they pulled the information from. So what do you do if you think that you might be at increased risk? Number one, you can talk with your primary care provider or your gynecologist, and you can discuss your family history, discuss your reproductive factors, everything that goes into risk modeling or talking about a risk evaluation or risk assessment. And then your primary care doctor or gynecologist could actually refer you to what's called the Breast Cancer Prevention Clinic at Prisma Health here in the upstate is where our location is. 900 West Ferris Road is our current only location, but your primary care and genetic and GYN providers can also help you with this. And you can also make a no-cost appointment at our Prevent Cancer Greenville prevention study to talk about your risk, and then from there even get referred to the Breast Cancer Prevention Clinic. And I will tell everyone a little bit more about that study in a minute, how to contact if you're interested. First, though, the Breast Cancer Prevention Clinic, as I said, at West Ferris, 900 West Ferris, the reason for most of our referrals in the Breast Cancer Prevention Clinic are, number one, diagnosis of atypical cells in the breast cancer. Number one, as in the first one on this list, not the number one reason, but atypical cells in the breast or on the breast pathology is a reason. probably our number one reason right now is this 5-year risk of greater than 1.7 on the NCI assessment tool called the Gale model. So taking a number like 1.7 out of the clear blue, it doesn't mean a lot taken out of context, but it is a number that the NCCN guidelines, which is National Comprehensive Cancer Network guidelines, recommend greater than 1.7 5-year risk for a woman. We should at least have a conversation about what is driving that risk. Is it atypical cells? Is it family history? Is it just reproductive factors and aging, which sometimes it is, but we can talk about what is that and what should we do about it? Do we need to talk to genetic counseling? Do we need to make other changes in imaging? Lifetime risk greater than 20%. This again, the lifetime risk average is 12%. So greater than 20% can make a woman meet criteria to consider additional imaging with, like, for instance, a breast MRI. All these topics are covered in the Breast Cancer Prevention Clinic. Chest radiation between the ages of 10 and 12. This is sometimes for like treatment for lymphoma or other cancer at an earlier age. And then a positive genetic pathogenic variant such as BRCA genes or CHEK2.
So LeAnn, how many people per month are you seeing in the breast cancer prevention clinic?
We right now are running right around 88 a month. We actually had the same amount in October as we had in the month of September. And so we have received about 1,350 referrals since April 1st, based only on the mammogram statement. There is a new statement that is on mammograms that started here in the upstate the 1st of April. And the statement that's on the mammogram tells a woman's 5-year risk if it's greater than 1.7 and their lifetime risk if it's greater than 20, and both if both happen to fall in those numbers. If neither of those are applicable to you, then there is no extra statement on the mammogram. So even though the mammogram may say normal mammogram, nothing abnormal in the mammogram itself, the next will be a statement of the 5-year risk or lifetime risk. And the 1,350 referrals that we've received since April 1st are from the mammogram statement only. And then we've received some others.
Is that a radiology society recommendation now, or is that just something that various places around the country are doing?
That's a complicated question. The lifetime risk of greater than 20%, I think, is especially radiology driven, because of the fact that if a woman's risk is greater than 20%, we may need to do additional imaging such as an MRI, and this certainly comes from radiology. The 5-year risk greater than 1.7 really probably comes more from a lifestyle or primary care. It is actually in the woman's medical record in Epic in the chart, which is the electronic medical record that we use, is Epic. And it is actually in there that primary care providers and gynecologists can actually see that number. So the importance of that number especially is that as the number gets higher, especially like over 3%, according to the NCCN guidelines, that there are medications that can be taken that can be used to decrease a woman's risk of cancer. So that's when that number really starts to become important. So atypical cells in the breast, or really high numbers based on some other factors. So that part is not necessarily radiology driven. And I don't know if that's being done too much across the country.
Right. So that's more of a local phenomenon that we've instituted. Yeah.
That to the best of my knowledge, although I know that a few other places throughout the country are doing that. Some other ones are finding it in a different place, like in the electronic medical record versus sticking it on a mammogram. And while I'll also say about that, it is sometimes alarming for a woman when they get a normal mammogram, and then there's a statement that says you might want to consider a visit in the breast cancer prevention clinic. So we take all that into consideration and appreciate that that's alarming. And we have a nurse navigator who speaks with people over the phone, explains about it, and then we bring them in. It's meant to be a big funnel to bring people in to talk about the risk and what we can do to decrease it. And the only other thing I'll say about that is that our women have been the ones who have come in. Now we've gotten referrals that people have opted not to come in, and that's fine. It's an optional visit, but we have gotten great feedback. Our women love the visit. We give all this information is covered in the visit, and I think that they like to be educated about their breast, and they are appreciating being educated.
Right.
So this here is the questions. So Dr. Jagir, you and I talked about this talk before today, and how you thought that it would be helpful to have these questions for people to be able to look at. So this screen's been up for a little bit now as we've been talking, but these are the questions that are answered by the woman at the time of mammogram, and then that goes into their into the software. The radiologist sees the information, sees the answer, and this is an example of what an answer looks like. So if the woman's 5-year risk is 2.5% for developing breast cancer, you can see the woman of this same age and information would be 1.3. And the questions that I showed a minute ago are not the answers that go to this, by the way. So if someone runs those questions, I just wanted to show an example of someone who was elevated on this answer sheet. And then you can see this woman in this answer actually has a lifetime risk greater than 20%. So this would certainly be a time of conversation about possibly medications, possibly risk factors that can be mitigated, and additional imaging.
So the 1.7 is for a 5-year risk of developing breast cancer, and the higher that is, the greater the likelihood of maybe talking more proactively about an intervention. But there's also a component to what they get from that scoring that gives them a feel for what their lifetime risk is as well.
That is correct. And of course, the older you get and the closer you get to 85, that 5-year risk goes up from a statistical model, statistically speaking.
Right.
You're closer to that age, the lifetime risk goes down from a statistical model. But as we know, as we talked about, non-modifiable risk factor is aging. So that pretty much wraps up the part, all the information I want to say about breast cancer. And then I'll tell a little bit about the study, because this is a good way for people to learn about their own risk of about 18 different cancers and what you can do to decrease your risk. And the information is based on your own medical history, your past history, your family history, the medications that you're on, pathology from previous Pap tests, from previous colonoscopies, from your mammograms. And this is an annual free of charge visit for anyone 18 and older who speaks English. And in the visit, you fill out information, questionnaire about your lifestyle habits, your past medical history, and then you do a body composition. We get your body percent fat, body percent lean, and then give each person some information on their risk of cancers and what you can do to decrease it. But in addition, you give two little tubes of blood. People don't always like to have blood drawn, but 2 little tubes of blood, a cheek swab, and urine specimen. And those are stored in a big freezer that we have for looking at later. We started this study in 2018. We have about 900 participants already enrolled, and we're continuing enrollment. This is an example of it's not filled out, but this is what it looks like, the education summary that each participant is given at the end of the visit. And this is an annual visit, as I said, and you give the biologic material annually. So sometimes things may not change much on this from year to year, but they might. People might make lifestyle changes from this, and that's part of the goal, is to educate people so that they can make the changes that they desire to make. So these are the cancers that are covered. Modifiable and non-modifiable risk factors are put on this sheet and discussed with the participant. So the goal is basically to provide cancer prevention today. Cancer prevention is educating on things that you can do to decrease your risk, and then also on screening recommendations to find cancers early. So primary prevention is doing something to prevent it. Secondary prevention is actually screening to find it early. And then the blood and biologic material is to look at later, look at molecular profiling, changes in blood, whatever it is that we're going to learn. If someone is interested in participating in the study, they can call this phone number, 864-455-2279, or email CCPW, which stands for Center for Cancer Prevention and Wellness, at prismahealth.org. And you will leave a message or email, and then someone will call you back to get you scheduled to come in and have an appointment. It takes about an hour and a half for the first appointment. These are the resources that I use for my talk today. The AICR is a fabulous website. Can't talk about it enough. Of course, American Cancer Society is great. Our Prisma Health website, you can learn on there about our department. And then densebreast-info.org is great. They have an FAQ section, a frequently asked questions section, that answers all questions about breast density, about risk with dense breast, and about additional imaging, and also about which states have the laws that we were talking about and which states are still advocating to get the law so that eventually all of the United States will have the same recommendations and laws. And that is it.
Thanks, LeAnn. As a participant enrolled in the Prevent Cancer Greenville study, I can tell you that you go in, and first of all, free. It's all paid for via philanthropic funds. They look at you year to year. One of the things that you will perhaps find when you're talking to your physician, when you are initially seeing that physician, they'll ask you about your problems, they'll ask you about your past history, and they'll ask you about your family history. And I'm as guilty as a physician, I'm as guilty of this as anybody. We don't ask about the family history anymore after the initial visit. And the family history evolves just like your, history of present illness. So it's important. And one of the things that they emphasize, has there been any change in your family history? Has anybody developed any other malignancies? Because that's a powerful statement as to whether or not you have potentially some, genetic predisposition. But the other thing they do is they really emphasize all the things you can do from a lifestyle standpoint that can make your risk factors decrease. And, I look at things from the standpoint of the measurements that they do at the time of the appointment, which is basically body composition in a very scientific way. But the blood work and the urine and the swab of your buccal mucosa, that's stuff that's all put in the biorepository and will be looked at later. But you can clearly objectively see yourself getting healthier by the recommendations based on body composition and other things. So I have looked at it as a very positive thing. And I think most of the patients that have participated feel the same way. One of the things that I would emphasize is that we are looking for more diversity in regard to our participants. So again, there should be no barrier from the standpoint of cost. Right. Obviously, transportation may be an issue and that sort of thing, but it's very important that we get a full biopsy of the demographics of this region, so that we get a good feel for what's happening there.
Yes, that is very true. And you're right, it is a very beneficial visit, and you're right about family history. And after the family history is taken, all of it is reviewed with a genetic counselor, who then makes recommendations about genetic counseling that patients may want, or participants may want to consider genetic testing. So it is definitely a worthwhile visit. And if a person comes for 1 year and decides they don't want to do it again, then they don't have to. You can unenroll anytime, but it is offered annually.
So one of the questions we have in the chat is, how common is DCIS in postmenopausal women? I don't know if that's something that's on the tip of your tongue.
I do not know. I mean, obviously, we see a lot of women with DCIS. I do not know the stats on that. Dr. Dreer, you may know the stats on that. But
yeah, I think probably it's of anything that we have to think about treatment for, it's more common than a breast cancer diagnosis. So this is ductal carcinoma in situ. Not in and of itself a malignancy. It does imply that there are malignant cells, but they are contained within the mammary ducts. They're not invasive. But it does sometimes, especially based on the grade, it sometimes implies the need for surgical radiation therapy and hormonal intervention.
yes.
Another diagnosis postmenopausally is LCIS, or lobular carcinoma in situ, which does not require therapy, but does imply that there's an increased risk of breast cancer, not only in the breast that it was found in, but also in the contralateral breast as well. And then there's a question, does hormonal birth control use affect breast cancer risk?
It does. There's a small increased risk. I actually looked the numbers up the other day, and it was like 1 in 7,900, I think, or something like that, of an increased risk. So there is a small increased risk, but some people want to take any risk out, but you have to kind of weigh the benefits of taking oral contraceptives or other contraception that adds hormones to your body, because obviously that we sometimes need to be able to control childbirth when we're not ready to have babies yet. So it's not to say that oral contraceptives are a bad thing or that that's bad. Most hormones that we talk about especially are postmenopausal hormone intake, and there is a place for that as well. So again, not saying that no one should ever take hormones. There is a place for all of it.
So everything's a risk benefit,
exactly
equation here.
And sometimes we need it for a little while postmenopausally to get to a certain point, or just for quality of life issues for a little while. And again, that's sometimes okay too.
Can you talk about family clusters of breast cancer, even if the genetics are negative? Would people still be advised or be benefited by coming to the high-risk clinic or the breast cancer prevention clinic in this situation?
Absolutely. So even when there's not genetics, if you have a family history that is significant, we have a number of family groups like this where, you know, mom, maternal aunt, sister all have breast cancer, but they've had genetic testing and it was negative, and maybe even the patient had genetic testing too. But there are still recommendations for increased surveillance in some of these women. So we still run these risk models. And when you start running the risk model, the Gale model that we talked about, or the lifetime risk, which is called IBIS or Tyrer-Cuzick, when you run those models, when you start putting family history in, you'll get a lifetime risk oftentimes of greater than 20%, indicating and meeting criteria to consider additional imaging with MRI, especially in the setting of heterogeneously dense breast or extremely dense breast. And then in addition, same thing, that 5-year risk greater than 1.7 or pushing up greater than 3 or 4 or 5 in a strong family history. There are times that endocrine therapy or medication taken to decrease the risk is warranted and desired by the patient. So it's worth coming in for a visit, worth getting your education. And then it's all, by the way, a shared decision-making visit. We don't tell anyone, you need to do this, you need to do that. It's all shared decision-making. What fits that person's life? What fits them all the way around? So again, benefits, risks, all discussed.
And there's the potential for follow-up as well.
Exactly. Yes, after a breast cancer prevention clinic visit, if a person is like, okay, thank you for the education, it was great, they can go back to their primary care if they want, or gynecologist, or if they want to manage, or if we're going to order things like MRIs or other, then yes, we will put them in for a follow-up in our clinic, and then we see those people annually. And we have women that we've been following since 2017. Our breast cancer prevention clinic was started in March of 2017.
Yeah.
The mammogram statement only started this year in April of 2022, but we've been at this for a good amount of time.
So if you have somebody who has a strong family history, maybe, there's a mother or a sister or an aunt that had breast cancer in their 30s or 40s, but they've had genetic testing, but it was 5 years ago. Is there a rationale, given the fact that these genetic testing batteries are changing and there's constantly the evolution of new mutations that are potentially placing people at risk that we're discovering? Is there a point, is there a period of time that, for my example is 5 years, would you think that you would maybe think about sending them back for more genetic testing?
There are times that is what is needed. So what we do is we look, if someone has had genetic testing, we look at that panel that they had done, and we see how many genes did they have tested. And then if we can't notice right off if all of them are covered, we have genetic counselors that we can review it with. But we look and see, for their family history, for what's going on in their family, did all the genes get covered at the time that they had the testing? So even if there are times women have testing that they had only, say, 1 or 2 years ago, but they did either a very small panel, or, as I said, just the BRCA genes. And so there are times that expanded panel beyond what they had done 4 or 5 years ago is warranted.
Any comment on the commercial genetic testing, 23andMe? That's what.
Yes. So 23andMe, especially, it's not covering all the gene mutations that we talk about, and the BRCA gene. I am not, by the way, a genetic counselor, but I recently had an updated conversation with our genetic counselors about this. And 23andMe covers, I do believe, the 3 most common BRCA genes that are especially run in Ashkenazi Jewish and history. But there are thousands of BRCA gene mutations. And so at a diagnostic lab, such as coming to our lab, you get all of those BRCA genes. So we have a lot of women who come in who have already done 23andMe, and that's fine. That may be all the information that they want. Maybe they've done it for their ancestry, in addition to, hey, I wonder if I happen to have any gene mutations. And that's fine if that's all they want. But if they feel like they got all the BRCA genes or all the risk of breast cancer, we like for them to know that that did not cover everything. So we have those conversations, and sometimes women will decide to do testing at the diagnostic lab with us.
I think it's very important and very reassuring that you're emphasizing that your appointment is not dictatorial. It is a conversation between you and the patient. You're telling them the facts about their situation, and based on their lifestyle, based on their druthers and whatnot, you help them make a decision that's right for them.
That's right.
So one of the things we talked about also was the need for increased diversity in the Prevent Cancer Greenville. One of the things that makes breast cancer potentially more curable, even if you develop it, is the fact that we can screen it early enough to find it in an earlier stage, which is curable. What about our more at-risk population that just doesn't have as much easy access to the screening techniques? What options for them?
Or do you mean maybe people who don't have health insurance or are underinsured? Is that your?
That's correct. Yeah.
Okay, we do. So in South Carolina, we have what's called Best Chance Network. And this is set up by the Department of Health and Environmental Control, DHEC, in the state of South Carolina to provide cervical cancer screening and breast cancer screening for uninsured or underinsured women who meet the financial criteria. So I actually have a phone number, and if it is actually, it's 1-800-450-4611, 450-4611. And this number, this is for women aged 21 to 64, by the way. And if a woman calls this phone number, they can find out if they're eligible and get information mailed to them to talk about how they can get connected in their own area, wherever they live in South Carolina, for breast and cervical cancer screening.
So not only for breast, but for cervical screening as well. That's correct.
That is correct. And we also have the mobile vans that do mammograms. We have a mobile mammography van, and they're on the Prisma website. You can actually look at the schedule as to where the van will be next. And you can, you have to register ahead of time, even for the mobile van, and you can go there and get your screening done. So sometimes, transportation is an issue. So maybe the mobile van is closer to you at some point. But we have mammography, as you know, all over the city, all over the state, but I mean, not in all little rural areas, but we have locations all over. So it's worth it to see if there's something close to where someone lives. For instance, Greenville Radiology over here near the hospital, Greenville Memorial, or Patewood over on the east side up in Greer. So the Prisma Health website has information about that too, different locations.
So if they're eligible for Best Chance, then DHEC will work with Greenville Radiology to make that happen.
That is correct. Yes, they go through the eligibility criteria and they can find out how to get connected to get their mammogram.
Can you read that phone number again?
I can. It's 1-800-450-4611. And it's called Best Chance Network. So even just going on, if a person has access to a computer or to their phone, looking up Best Chance Network, you can find even more information about it and the eligibility criteria. Again, it's for ages 21 to 64. 65, assuming someone's usually moving into Medicare at that point. And then cervical cancer screening should at least take a look at around the age of 21.
LeAnn, I can't thank you enough for all your comments. Let me see if there's something else here. You mentioned that estrogen can elevate breast cancer risk, but also breast cancer risk is elevated by age or postmenopausal status. When estrogen level is lower. Can you explain this? Let me just read that again, because so estrogen is a risk factor if you take it, exogenously and whatnot. But obviously, age when you're postmenopausal and estrogen level is lower is also a risk. So how those they imply a little disparate. Just give them the explanation for that.
Okay, so I'm guessing that I don't fully understand, but it sounds like postmenopausally, your estrogen levels are already low.
Right.
So asking is it okay to put estrogen in? You already have low estrogen levels. So what's the difference of putting estrogen in? And so first of all, if you have not had a hysterectomy, if a person still has their uterus, you cannot, or is not recommended to take estrogen postmenopausally without taking progesterone in addition. So you don't take unopposed estrogen. If
Right.
you do, this increases the lining, the thickening of the uterus, and increases the risk of uterine cancer greatly. So right there we have already, now there's another hormone to look at. So that's combination therapy, which when you look at the Women's Health Initiative study, some of the other information coming from that right now, the way we know it, it looks like combination hormone replacement therapy as in estrogen and progesterone can increase the risk of breast cancer. If you don't have your uterus, you've had a hysterectomy, then taking estrogen, there's a lot of back and forth. Staying up to date on that, looking at some websites like American Cancer Society or ASCR would be the best thing, since this is recorded and things change as time passes. But as I did say, there is a time and place for everything. And the latest information that I read recently about estrogen and taking hormone replacement therapy after menopause was taking it close to right after going through menopause increased the risk more than going through menopause for a couple of years, a few years on your own, and then adding in some hormone replacement therapy. So that is different, different information. Anyway, that's it. That's all I'll say about that, because it's a complicated topic.
Well, and obviously, as we age, we have more risk for DNA disrepair and more mutations. So that increases the risk from just being senescence of cells.
This is true.
Well, thanks so much. I will note that Rachel has put a link to a website for Best Chance Network for anybody that's listening. This is a community, guys. We have to make sure that if this was important to you, and you know it would be important to somebody else that you love or you associate with, make sure that you make them aware that this is recorded and will be on the Cancer Survivors Park website. So, LeAnn, thank you.
Thank you, Dr. Jagir, so much. It was nice. I appreciate the questions and the interactiveness of the whole talk.
Yeah, thanks. And then December 8th, we'll be talking about all kinds of screening for various cancers, some of which the screening you're aware of, and some malignancies where you can't necessarily screen for the entire population, but there is a subpopulation that if you can identify, you can screen appropriately for, such as lung cancer, pancreatic cancer, and whatnot. So we'll be talking about that December 8th from 5:30 to 6:30. And as per usual, we're going to end with a little poem. Now, LeAnn, I'm going to ask you a question. This is a poem that was written by Shel Silverstein. Have you heard of Shel Silverstein before?
I have not.
So have you ever heard of The Giving Tree?
I have.
Yeah, well, he wrote that.
Okay.
And there's a picture of him. He's a very intimidating Black man.
Okay.
But he writes poetry. And so do you remember Johnny Cash?
Oh, absolutely.
Absolutely. So one of Johnny Cash's #1 hits was A Boy Named Sue.
Yes.
Shel Silverstein wrote that.
Oh, okay.
So that's a little tidbit for you Johnny Cash fans out there. But the poem tonight is Hug of War. I will not play tug of war. I would rather play hug of war, where everyone hugs instead of tugs, where everyone giggles and rolls on the rug, where everyone kisses and everyone grins and everyone cuddles and everyone wins.
Oh, that's
you guys have a great Thanksgiving, and we will see you before Christmas. And thank you for attending, and share with your friends. Good night.
Bye.